Uh, Hello, I'm Dr. Harish BS, consultant radiologist at Radiology Solutions. Today I'll be speaking about the imaging of the prostate gland. The prostate, as we know, is an inverted pyramid that surrounds the proximal urethra, and with the proximal urethra traverses the prostate close to its anterior surface. The base of the prostate is continuous with the bladder, whereas the apex is at the urogenital diaphragm. The relationships of the prostate gland are follows. Anteriorly, there is the pubic symphysis. Inferiorly, we have the urogenital membrane. Superiorly, we have the urinary bladder. Posteriorly, the rectum. And laterally, we have the prostatic venous plexus and levator ani. So these images demonstrate the anatomic relationships of the prostate gland. Superiorly, we have the prostate, wherein the base of the inverted pyramid, that is the prostate, is towards the urinary bladder. Then posteriorly, we have the rectum, and superiorly superolaterally, we have the seminal vesicles on either side, and inferiorly, we have the urogenital diaphragm. So the ejaculatory ducts open into the prostatic part of the urethra at the the normal prostate is an organ which is palpable via rectal examination. The ejaculatory ducts pierce the posterior surface of the prostate below the level of the prostate, below the level of the urinary bladder. The prostate is comprised of three distinct zones with different embryologic origins, that is the peripheral zone, central zone, and the transitional zone. The peripheral zone constitutes approximately 70% of the total prostate volume, and it surrounds the distal urethra at the apex of the prostate and extends posterolaterally to the base. The peripheral zone is deficient anteriorly, where it is filled by the anterior fibromuscular stroma. The central zone constitutes about 25% of the prostate volume, and it contains the ejaculatory ducts. The transition zone, which is predominantly lies lateral to the proximal urethra, constitutes the remaining 5%. We can see this diagram which shows the cross-sectional and the longitudinal anatomy of the prostate. Here we can see anteriorly we have the anterior fibromuscular stroma, then and in the center, in the anteriorly we have the periurethral zone, which is around the urethra. Then laterally we have the transitional zone. Then we have the central zone, and peripherally we have the peripheral zone. So this is the MR anatomy of the prostate. We have the central hypoechoic central zone and the hyperintense peripheral zone. And anteriorly we have the hypointense fibromuscular zone. This is the sagittal image which demonstrates the peripheral hyperintense zone and the central hypointense zone. Superolaterally we have the seminal vesicles, and superiorly we have the urinary bladder. The normal prostate has two capsules. One is a true capsule and then the fibrous pseudocapsule. True capsule is a thin layer of connective tissue at the periphery of the prostate gland. Pseudocapsule is formed by three distinct layers of fascia: anterior, lateral, and posterior fascia. Anterolateral fascia is in direct continuity with the true capsule. Laterally, the fascia fuses with the levator fascia. Prostatic venous plexus lies between the true and the pseudocapsule. The arterial supply of the prostate is from the inferior vesical artery, which is a branch of internal iliac artery. Sometimes even branches of the middle rectal arteries provide branches to the prostate. Venous drainage is through the prostatic venous plexus, which communicates with the pudendal plexus to the deep dorsal vein, with some communication to the Batson vertebral venous plexus, which explains the frequent metastasis of the prostatic cancer to the vertebra. The normal prostate on ultrasound is best evaluated on transrectal ultrasound. The zonal anatomy is best distinguished on the better distinguished on transrectal ultrasound. The outer gland, that is the central and the peripheral zone, appear uniformly of low echogenicity, but the inner gland is more echogenic than appears more echogenic than the outer gland. CT is basically it is poor to assess for the assessment of the zonal anatomy and pathology, but it is useful for as far as staging of the metastatic prostate cancer is concerned. The central zone usually appears hyperdense between 40 to 60 HU, and the peripheral zone appears hypodense between 10 to 25 HU. This anatomical zonal variation is nicely distinguished, especially when there is benign prostatic hypertrophy. The MRI is now the preferred modality of choice for the evaluation of prostate, especially in malignancy of the prostate. The T2, the normal prostate appears homogeneously intermediate signal on T1, and T2, the anterior fibromuscular stroma is of low intensity on T1 and T2. Peripheral zone is T2 hyperintense, similar to or greater than the adjacent fat. Then there is age-related increase in T2 weighted signal. Peripheral and the central and transitional zones are of lower T2 signal than the peripheral zone. The true capsule appears as a thin rim of low signal intensity, and the distal urethra is a low intensity ring. The coming to the transrectal evaluation of the prostate, it basically improves the diagnostic ability compared to the transabdominal ultrasound, and it plays an important role in many prostatic diseases. It is necessary as for prostatic biopsies. If the PSA levels are elevated or are increasing rapidly, or there is an abnormal prostate examination, then a transrectal examination and prostate biopsy is indicated to obtain tissue to make the diagnosis of prostate cancer. Transabdominal ultrasound is basically primarily used for evaluation of volume of the prostate. The zonal anatomy is not very well delineated on the transabdominal ultrasound. And another limitation of transabdominal ultrasound is the urinary bladder has to be full for up to at least 60 ml for the volume to be accurate. Here we see the transrectal ultrasound used for evaluating the volume. As we see that the zonal anatomy, the difference between the peripheral zone and the central zone are better delineated on the transrectal ultrasound. So it is better for evaluation of focal lesions in the prostate compared to the transabdominal route, which is basically used for evaluation of the prostate volume. Next we come to benign prostatic hyperplasia. Here it is important to remember that we have to use the term hyperplasia rather than hypertrophy, because it is basically an increase in number of the epithelial and stromal cells in the periurethral area of the prostate, and not an actual enlargement of the cells, so as to say. So that is the reason it is called as hyperplasia. By the age of 60 years, 50% of the men will have BPH, and by the age of 90% of the men, the incidence increases to 90%. And it is thought to be an essentially a normal part of aging. The clinical presentation of BPH includes straining, hesitancy, frequency, incomplete emptying of the urinary bladder, and nocturia. The PSA levels may be elevated, and it is basically a non-specific finding. On ultrasound, the increase in volume can be calculated using the formula width into height into length into 0.52. Basically the benign hypertrophy involves the central gland, which is enlarged and appears hypoechoic or of mixed echogenicity. Calcifications may be seen both within the enlarged gland as well as in the pseudo capsule. Another important use of ultrasound is in the evaluation of the post-micturition residual volume, which is useful for management purposes. The grading of prostate gland enlargement is done basically according to the volume of the gland. Grade 1 is considered to be between 21 and 30 cc, grade 2 between 35 to 50 cc, grade 3 between 51 to 80 cc, and grade 4 80 cc and above. The median lobe of the volume is also added to the total prostatic gland volume. On IVP, basically the benign BPH will appear, will cause the elevation of the bladder base and the lifting of the medial ends of the distal ureters, and giving the characteristic picture of J-shaped ureters or fish hook-shaped ureters. Then there will be additional findings of chronic bladder outflow obstruction due to leading to detrusor hypertrophy, trabeculation, and formation of diverticulum. CT it's typically not used to assess prostate, and BPH is more frequently an incidental finding. MRI demonstrates the enlarged central zone, which demonstrates heterogeneous signal with an intact low signal pseudocapsule in the periphery. This is an ultrasound image demonstrating an enlarged prostate gland and an enlarged median lobe which projects into the urinary bladder. An MRI image which demonstrates the gross hyperplasia of the central gland compared to the thinned out and compressed peripheral zone. Next we come to the prostate cystic disease. So the cysts of the prostate gland are basically divided into midline and the lateral cystic lesions. The midline cystic lesions include the Mullerian duct cyst, prostatic utricle cyst, ejaculatory duct cyst, cystadenoma of the prostate, vas deferens cysts, and TURP defect. The lateral cystic lesions include the cystic degeneration of benign prostatic hypertrophy, prostatic retention cyst, seminal vesicle cyst, diverticular prostatitis, prostatic abscess, cavitary prostatitis from chronic prostatitis, then parasitic prostatic cyst, and cystic prostatic carcinoma. This image demonstrates a midline cystic structure within the prostate, which is a prostatic utricle cyst. Prostatitis refers to an infection. Next we come to prostatitis, which is basically an infection or inflammation of the gland. It is basically a clinical diagnosis, and imaging. The role of imaging is mainly to exclude abscess formation. According to the National Institute of Health, the prostatitis is divided into 4 distinct syndromes: acute bacterial prostatitis, chronic bacterial prostatitis, chronic prostatitis with chronic pelvic pain syndrome, and then the asymptomatic inflammatory prostatitis. Contrast CT is the best tool for imaging of the suspected abscess, which demonstrates a diffusely enlarged and edematous gland with the predilection for peripheral zone involvement. When an abscess is present, it appears as a remanenting unilocular or a multilocular hypodensity in the peripheral zone. Central zone is involved in is usually encountered in cases of post-TURP cases. The infection can extend through the capsule into the periprostatic tissue, seminal vesicles, and peritoneum. Ultrasound demonstrates the abscess as a focal hypoechoic area in the peripheral zone of the gland. Discrete fluid collection would suggest abscess formation. The prostatitis will appear as increased vascularity on the color Doppler evaluation and in the periphery of the abscess. MRI again basically demonstrates a diffuse enlargement of the gland, and there may be associated inflammatory changes in the periprostatic fat and seminal vesicles, and there is diffuse enhancement of the gland on post-contrast images. Here we see the CT image, which demonstrates the diffusely enlarged prostate gland with an ill-defined remanenting fluid collection consistent with an abscess. Similarly, on the ultrasound, post-contrast MRI demonstrates diffusely enlarged gland with a large abscess, multiple abscesses with one of the abscesses extending posteriorly into the periprostatic soft tissues. The ultrasound can also detect the presence of abscesses in case of prostatitis. Then next we come to the prostatic carcinoma, which ranks as the most common malignant tumor in men and the second most common cause of cancer-related deaths. The prostatic adenocarcinoma is by far most common histological type. Cancer is usually detected by an elevated prostate-specific antigen greater than 4 nanograms per deciliter. The normal is considered to be between 1 to 4 nanograms per deciliter, and an abnormal digital rectal examination. The prostatic cancer usually arises from the peripheral zone near the rectum, where it can be easily identified by screening digital rectal examination. So these two are the initial two screening methods. That is, the one is the PSA levels, and then the abnormal digital rectal examination. These two abnormal findings should be a precursor for further evaluation of the prostate for cancer. So 95% of the prostate cancers are adenocarcinomas and develop within the acini of the prostate glands. They arise in the posterior and peripheral prostate more commonly than the anterior and central prostate, which constitutes only about 30% of the cases. The local invasion can occur into the bladder, seminal vesicles, urethra, and rectum. Lymphatic spread can occur to pelvic lymph nodes in the para-aortic and inguinal regions, and there can be hematogenous metastasis. The common sites of hematogenous metastasis according to incidence is the bone, where it occurs in 90% of the cases, lungs 45%, liver 25%, pleura 20%, and adrenal glands 15%. The pathological specimens are generally graded using the Gleason score, which is the sum of the most prevalent and second most prevalent types of dysplasia, each on a scale of 1 to 5, with 5 being the most dysplastic and carrying the poor prognosis. Next, we come to the staging of the prostate cancer. Here, the TNM staging is used. The primary tumor staging is as follows. When a T1 involves basically a tumor which is non-palpable on digital rectal examination or is seen on the transrectal ultrasound. The T1A is a cancer found incidentally during TURP, which constitutes less than 5% of the gland. Then T1B cancer found incidentally, but over 5% of the gland is involved. T1C is found by needle biopsy for a raised PSA level. So T2 involves a palpable abnormality on digital rectal examination, but it is confined to the prostate. T2A is less than half of one lobe. T2B is more than half of one lobe. T2C is cancer involving both lobes of the prostate. T3 staging involves spread to outside the prostate. T3A involves extracapsular extension on one or both sides. T3B involves tumor invasion into the seminal vesicles. T4 spread involves spread into the adjacent tissues other than seminal vesicles. For example, the bladder, sphincter, rectum, liver ani, or pelvic side wall. The nodal classification, which is basically involves 1 centimeter short axis cutoff, is used for on CT. N0 means no spread to lymph nodes. N1 means one or more nearby lymph nodes are involved. Metastasis staging involves no spread beyond the regional lymph nodes. M1 spread beyond the lymph nodes. M1A distant lymph nodes outside the pelvis. M1B bony metastasis, M1C other organ involvement independent of bony involvement. That is example is lungs, liver and brain. So this is the stage grouping for the various staging of carcinoma prostate. The transrectal ultrasound is often the initial modality performed, usually followed by an abnormal PSA level or digital rectal examination. Ultrasound is used to direct biopsy of the suspicious hypoechoic regions, usually in the peripheral zone. On ultrasound, prostate cancer is usually seen as a hypoechoic lesion. In 60 to 70% of the cases, it's in the peripheral zone of the gland, but can be hyperechoic or isoechoic on 30 to 40% of the lesions. Transrectal ultrasound is also the modality of choice for directing brachytherapy seeds into the prostate gland. Here we see an image of a stage 2B organ confined disease, wherein a hypoechoic nodule is seen within the peripheral zone of the prostate, and it is confined to within the gland. So it is an organ confined disease. Here is another example where there is a hypoechoic lesion with there is some fuzziness of the margins, and the capsule is ill-defined in this region, which suggests a lesion which has extracapsular extension. So next modality of choice would be the MRI. The primary use of MRI is in the detection of extracapsular extension, wherein it can detect the extension of the lesion beyond the true capsule. It is used to detect and localize cancer when the PSA level is persistently high, but the routine transrectal ultrasound may be negative. Transrectal ultrasound guided biopsy is negative. Both the American College of Radiology and European Society of Uroradiology advocate the use of multi-parametric MRI in prostate imaging. MRI-guided prostate biopsy is also used, particularly in those cases where trust biopsy is negative, but clinical and PSA suspicion remains high. Following radical prostatectomy also, patients with elevated PSA should undergo MRI evaluation to rule out recurrence. The signal intensity characteristics involved is on T1 imaging is basically useful for detection of prostate contour, the neurovascular bundle encasement and post-biopsy hemorrhage. T2 imaging is done using an endorectal call, and T2 weighted images of the prostate cancer usually appear as region of low intensity in the high signal peripheral zone. So any focal lesion which has a low signal intensity in the peripheral high signal zone should be suspicious for a prostatic malignancy. Most significant cancers occur along the posterior portion of the gland abutting the rectum. The MRI parameters routinely assessed include the presence of a mass with low T2 signal and restricted diffusion with reduced ADC, increased tissue permeability that demonstrates as contrast enhancement on dynamic gadolinium images. The diffusion weighted images usually show restricted diffusion. Dynamic contrast shows enhancement, but it may be difficult to distinguish prostatitis, from prostatitis or benign prostatic hyperplasia, especially if there is it involves the peripheral zone. In case of peripheral zone lesions, more specific than T2 signal and involves post-processing time. Extracapsular extension carries a poor prognosis, asymmetry and extension into the neurovascular bundle, obliteration of the, these are the parameters which are used to evaluate the extracapsular extension. One is the asymmetry and extension into the neurovascular bundles. Then there the obliteration of the rectoprostatic angle, involvement of the urethra, extension into the seminal vesicles. Generally, the normal seminal vesicles have high signal on T2, which is obliterated in case of seminal vesicle infiltration. Then lymphadenopathy is best evaluated on T1 weighted images. Next, coming to MR spectroscopy. MR spectroscopy is mainly based on the choline peak elevation and choline creatinine ratios. in case of prostate. The normal prostate produces large amount of citrate from the peripheral zone, whereas the tumors do not produce the citrate. In normal prostate tissue, citrate and polyamine levels are high and choline levels are low. The reverse is true in cases of tumor. So the choline creatinine ratio, choline creatinine to citrate ratios are as follows. That is, greater than 0.05 is suspicious, greater than 0.8 is very suspicious, and greater than 2 is definitely abnormal. Additionally, the peak heights of citrate and choline can be compared visually. So this is the case of T2-NO-MO disease, wherein the tumor is confined to within the gland, and it appears as a slightly hyperintense lesion in the it appears as hyperintense lesion in the peripheral zone. The central zone is spared in this condition. There is no extracapsular extension of the tumor in this case. Another case of T2 staging, wherein the tumor appears to be confined to within the gland and the periprostatic tissues are clean. Then we have another case wherein there is a large tumor in the transitional zone, and the tumor causes bulging with interruption of the low signal intensity of the anterior fibromuscular stroma by significantly higher signal intensity tumor, suggestive of anterior extracapsular extension. So the loss of the very low signal intensity anterior muscular fibrostroma in case of anterior tumors should raise suspicion of extracapsular extension, as is demonstrated in this image. Next, we have a T3 disease, wherein the tumor has extended beyond the prostate, the capsule of the prostate, and involved the seminal vesicles bilaterally. So this is the T3 disease. We also have a corresponding MR spectroscopy image which demonstrates the elevated choline levels that is consistent with, and the decrease in citrate levels, which is the typical spectroscopic finding in the cases of prostate cancer. Next, this is the T3 disease, wherein there is infiltration of the tumor into the seminal vesicles bilaterally. The high signal is obliterated here in the proximal portion of the seminal vesicles bilaterally, consistent with tumor infiltration. CT, although not accurate for detecting in situ cancer, prostate cancer, especially in T1 and T2 stages, basically scanning of the abdominal pelvis, normally CT scanning is basically obtained prior to onset of radiation therapy to identify bony landmarks for planning. Then in case of advanced disease, CT is the test of choice to identify the enlarged pelvic and retroperitoneal lymph nodes, hydronephrosis, and blastic metastasis into the bones. When combined with PET-CT, it is a useful tool for evaluating malignancy and metastatic disease. Nuclear medicine, we have the Technetium 99 MDP bone scans, which are useful for detection of metastasis. This is a CT image which demonstrates a focal contour abnormality in the prostate with extension into the left posterolateral periprostatic tissues. Here we have the nuclear scan, which demonstrates diffuse osteoblastic metastasis into the vertebrae, into the and in the other bones. The radiograph which demonstrates the diffuse blastic metastasis in the pelvic bones. And when CT is combined with PET-CT, it's very useful for detecting the tumor activity and for follow-up examination after treatment. These are my references. Thank you.